pancreatic cysts are being detected with increasing frequency due to advances in and a rising use of imaging technology. A recent study suggests that only 2% of cysts are malignant at diagnosis. The remaining patients have non-malignant disease with only 0.4% chance of malignant transformation per year of surveillance. Clinicians are thus faced with an epidemic of patients with pancreatic cysts who must be triaged to surveillance or surgery, the goal being to identify the minority of cysts with high malignant potential as early as possible while limiting unnecessary surgery. Due to the high mortality rate of pancreatic cancer, international consensus, SENDI, American College of Gastroenterology, and European Study Group on Cystic Tumors of the Pancreas treatment guidelines take a cautious approach and recommend resection for most cysts with any worrisome feature associated with malignancy. However, the guideline recommended criteria alone cannot accurately stratify patients for risk of malignancy, given that about 60 to 80% of surgeries reveal non-malignant disease. Such a cautious management approach results in unnecessary morbidity. Consequently, modalities that reduce aggressive treatment of indolent disease while facilitating early detection of cancer are needed to supplement current guidelines. Molecular profiling of pancreatic cyst fluid has shown that high levels of high-quality DNA, loss of heterozygosity of tumor suppressor genes, and KRAS point mutation correlate with malignancy. However, none of these molecular features can individually determine malignancy risk. Similarly, the guideline recommended tests of imaging, cytology, and fluid chemistry, amylase and/or carcinoembryonic antigen, may identify features that guide decisions regarding surgery, but cannot accurately determine the risk of malignancy individually, with the exception of a definitive malignant cytology result, which occurs in the minority of cases. In most cases, the integration of all molecular and clinical test results is required to provide an enhanced level of diagnostic and predictive information. Integrated molecular pathology (IMP) testing of pancreatic cysts may be prescribed when patients lack definitive malignant cytology results and combines molecular analysis with clinical test results to assess malignant potential. In their study entitled Integrated Molecular Pathology Accurately Determines the Malignant Potential of Pancreatic Cysts, Al-Haddad et al. Aimed to establish the clinical performance of IMP in diagnosing pancreatic adenocarcinoma in patients with pancreatic cysts that lack definitive malignant cytology results, and in risk stratifying these patients for such malignancy. They assessed the clinical performance of a Sendai 2012 criteria model for surgery or surveillance decisions, and the clinical utility of using IMP under these management guidelines, and assessed the ability of IMP testing to improve current management strategies. Here is what they have to say. Background and study aims. Current diagnostic testing is inadequate to determine the malignant potential of pancreatic cysts, resulting in overcautious patient management. Integrated molecular pathology (IMP) testing combines molecular analysis with first-line test results, namely cytology, imaging, and fluid chemistry, to assess the malignant potential of pancreatic cysts. This multi-center study aimed to determine the diagnostic accuracy of IMP for pancreatic adenocarcinoma and the utility of IMP testing under current guideline recommendations for managing pancreatic cysts. Patients and methods. Patients who had undergone previous IMP testing as prescribed by their physician and for whom clinical outcomes were available from retrospective record review were included. Number 492. Performance was determined by correlation between clinical outcome and previous IMP diagnosis as benign or statistically indolent versus aggressive or statistically higher risk, or an international consensus guideline Sendai 2012 criteria model for surveillance versus surgery. The Cox proportional hazards model determined hazards ratio for malignancy. Conclusion. An IMP diagnosis of benign or statistically indolent is a highly reliable predictor that a pancreatic cyst is benign and has low potential for malignant transformation over a median follow-up of about 3 years in patients who lack definitive malignant cytology results. Furthermore, statistically higher risk and aggressive IMP diagnosis identify patients who are at significantly higher risk of pancreatic adenocarcinoma. IMP is more accurate than Sendai 2012 criteria in risk stratifying patients according to their potential for pancreatic adenocarcinoma. IMP may therefore improve guideline-recommended patient management strategies by increasing confidence that observation is more appropriate in the majority of patients who are likely to have a benign disease course. In a minority of patients, close surveillance or surgical consultation may be necessary due to significantly higher risk of pancreatic adenocarcinoma. IMP is therefore able to limit the overtreatment of inconsequential disease while accurately detecting cancer, which is an essential characteristic of a clinically useful diagnostic test.